to today's webinar with the Accountable Care Learning Collaborative. My name is Sean Matheson, and I'll be moderating today's call on specialty ACOs and the Oncology Care Model. So we're really excited today about the presentation and the opportunity to hear from Dr. Robert Chapman and Tina Burch, who will share insights about their organization's involvement with oncology care management. So just a few housekeeping items I'd like to cover before we get started. To minimize any feedback, please mute your line. If you're dialed in, please use your phone's mute feature, or if you're using your computer only, please click on the microphone icon and mute that way. If you're using both a phone and a computer, it's usually best just to select that telephone option under Audio in the GoToWebinar window and then mute your phone from there. So we should have the opportunity at the end of this presentation to take questions, and if you'll submit those at any time during the presentation, you can just use the questions box of the GoToWebinar window. We really appreciate your questions. So we'll plan on covering a couple of things today. I'll introduce our guest speakers, Dr. Robert Chapman and Tina Burch, and Dr. Chapman will present on Henry Ford's experience implementing the OCM. And Tina Burch then will present on Bon Secours' experience doing the OCM at her organization. And again, we'll have some time for questions during the session, so we'll take those as we go along. So I'd like to introduce Dr. Robert Chapman. He's Division Head and Senior Staff Physician in Oncology Hematology at Henry Ford Health System. Dr. Chapman has over 30 years of oncological practice experience, working with multiple steering committees and work groups in the field. Dr. Chapman received his MD from Cornell University Medical College. So at this time, Dr. Chapman, we'll turn the time over to you.
All right, thank you very much. I'm delighted to be here. The OCM, as many of you I'm sure know, is a demonstration project that was created by CMMI, the Center for Medicare and Medicaid Innovation. And the CMMI is authorized to test innovative payment and service delivery models that have the potential to reduce expenditures, and that's the key, while maintaining quality of care. The OCM, or the Oncology Care Model, is an episode-based payment model that incentivizes high-quality care for beneficiaries undergoing chemotherapy. A few key terms that, let's see, I can't control the slides. Can you move on to the next slide for me? Okay, I need you, can you guys advance the slides? I cannot. All right, well, I'll just continue on, even though the slides may not move.
No, do you see, Dr. Chapman, do you have the key term slide there? Do you see that now?
Now it's up, yeah.
A little bit of delay sometimes.
I'll just tell you guys when to move ahead with each slide. A few key terms just to help you understand a little bit what the OCM is all about, and then I will talk a little bit about what Henry Ford is doing in particular to address our participation in the OCM. PGP, Physician Group Practice. Each of the participants in the OCM is a practice, and the practice is defined by physicians who are all practicing under a single tax identification number. The real hook that I think led to many practices to apply to be part of the OCM are the MEOS payments, which are monthly enhanced oncology services payments. And basically what that means is when a patient who is an eligible Medicare patient is begun on chemotherapy of virtually any kind, that starts the clock for a monthly payment of $160 per beneficiary per month for at least 6 months. If the treatment goes beyond those 6 months, even one day beyond the 6 months, it triggers an additional 6 months of MEOS payments. And the main reason for those is to pay for the enhanced services, which I'll be describing soon. what we are required to provide is 24/7 access of the beneficiaries to a practitioner who has real-time access to the EMR. We have to provide care that is consistent with nationally recognized guidelines. For us in oncology, that's principally the NCCN guidelines. And we have to have well-documented care plans that include the 13 components of the Institute of Medicine management plan. If you go on to the next slide, what do we mean by an episode? An episode is a 6-month period, and what is looked at during that 6-month period are all expenditures that come down to CMS and services provided during that defined 6-month period. And when I say all, yes, these are initiated by starting chemotherapy, but if the beneficiary walks out of the clinic, is hit by a car, comes into the ER, has all kinds of trauma surgery, those expenses count. It's not just the chemotherapy-related expenses. In addition to the MEOS payments, there are also performance-based payments. These are payments that are given out on a semi-annual basis, and they are based on meeting specific savings and quality metrics that are outlined by CMS and determined by metrics which they define. On the next slide, some of the practice redesign requirements. Every participant must have what they consider a certified electronic health record. For us, it happens to be Epic. I suspect as widespread as Epic is, that's the case for many of the participants. As I mentioned, we're required to provide 24/7 access to a clinician with real-time access to the EHR. We have to generate, collect, and manage and analyze data that is generated from the demonstration project to utilize for continuous improvement in our own participation. And we have to provide core functions of patient navigation, things like coordinating appointments with providers, diagnostic testing, and the navigators should be able to communicate in real time with beneficiaries in the program. Next slide. Some of the key quality metrics are things that, frankly, are things that are partially controllable that clearly drive up the cost of care. Emergency department admissions, hospital admissions per episode, particularly non-elective hospital admissions, and something that's easy for CMS to measure and something that we are going to focus on a lot. They will look at the percentage of patients admitted to hospice during the last 3 days of life. Obviously, the lower that percentage, the better. So what are the things, some of the things, next slide, that we are doing specifically to ready ourselves to participate and really make this worthwhile? We have spent a tremendous time working with our own IT departments, our electronic medical record, to do things which are seemingly simple, like automatically identifying eligible patients in real time as they initiate chemotherapy. We've been also working with them to establish a process that will automatically trigger appropriate episode-based billing for our patients. There's an entirely separate, independent set of billings for patients who are in the OCM. We also have begun a very deliberate process on determining whether to employ a one- or two-sided process for the semi-annual performance review. CMS, with this performance-based payment that is semi-annual, has set two possible ways for participants to recoup additional reimbursement. There's a one-sided model in which you're expected to generate 4% savings over benchmark, and if you do, then there's sharing in those additional savings as long as you are reaching the other established quality benchmarks. The two-sided reimbursement, you only have to create savings that are 2.75% below the benchmark. However, if you fail to achieve that, then you're required to repay the difference to CMS. So it's a lower bar with a real stick or carrot, depending on your confidence level of achieving it. Next slide. What are some of the initiatives that we have taken? For the 24/7 access, we have created a single phone number that patients may call, which will allow them to reach our hematology oncology fellow on call. We have a fellowship program. There are 12 fellows, four second and 4 third-year fellows, who all have access to the EHR on their cell phones, so that they can assist a patient 24/7 should the need arise. This number is also being provided to practitioners in the emergency department with the expectation that when problems arise there, we may be able to help them expedite a more efficient transit through the emergency room. We've also established what we are calling an Oncostat clinic. Should, for example, a patient call a fellow at 3 o'clock in the morning, they can send a message via our EHR to an appropriate clinic, and that patient can be seen the next morning in the clinic to address their problems. Obviously, the fellow will be acting as a triage. If it's a major emergency, they may send the patient directly to the emergency room, or if it's something minor they can handle over the phone, they will do that as well. But the Oncostat clinic itself, patients may walk in the same day. It will be staffed primarily by advanced practice practitioners, and it will be available at all of the ambulatory sites where we have oncology clinics. We've established something we call a high-risk monitoring program. Clearly, patients who have admissions to the emergency department or admissions to the hospital that were unplanned will automatically qualify for high-risk monitoring. We had established some time ago a program we call OCMP, or our Oral Chemotherapy Management Program, which was something that our oncologists just did voluntarily together with our IT people and our pharmacists and our RNs. As we began noting several years ago that more and more of our patients were receiving oral rather than parenteral chemotherapy, we became very insecure, because with people receiving parenteral chemotherapy in our clinics, we knew exactly what they got, when they got it, how much, and what at least acute problems they might be having, so that we had an immediate real-time understanding of compliance. When we write a prescription for an oral agent, which might be every bit as potentially toxic as the parenteral agents, they take the prescription, they walk out the door, and potentially enter a black hole until they come back to the clinic. So we developed a set of algorithms for our RNs and our pharmacists. We tied it to our EHR so that when a patient is started on an oral medication, in addition to the consent and information the patient will get directly from the physician, once the order is entered in the EMR, pharmacy will initiate a pre-authorization process to help assure the patient's able to acquire the medication on time. And RN, before the patient even leaves the clinic, will provide additional teaching explaining that they'll be calling the patient at or around the time they should be picking up and initiating the prescription, and they will be asking a templated set of questions depending on the regimen they are on to determine if the patient is having problems, whether the problem may be caused by the medication or the underlying disease, and they will triage the type and severity of the problems to either deal with it on the phone, have the patient come to the Oncostat clinic, the emergency room, or whatever appears necessary. And there will be follow-up phone calls depending on how things go with the initial calls, so that we will have a handle on what happens to our patients on oral medications once they leave the door. And with the OCM, we will be expanding that same process for patients receiving parenteral medications as well. Next slide. Very clearly, one of our key relationships has got to be with our emergency room. And so we've established a number of meetings with them, helped them understand that this program was going into effect. We've developed new communication algorithms between oncology and the emergency room physicians, so A, they can use that phone number to reach our fellows, and B, we can work with them as oncology patients come in the ER to help them triage and establish appropriate transitions from the ER. I mean, in the emergency room, at least in our organization, it's a place where, you know, if there's a question about a symptom, they may be very quick to order advanced imaging, for example, more quickly than we might if we already know more about the underlying disease problems than the emergency physician who may be seeing the patients for the first time. And certainly, once patients get there, we will do everything we can to include them on the high-risk monitoring program, but we'll also educate patients up front to help assure that they come to one of our sort of in our health system emergency rooms, because if they go outside the system, we may not, to an emergency room, we may not be aware that they've even gone to an emergency room and required that kind of care until long after the fact, without having had any opportunity to interface and help expedite the situation. Next slide. We are working hard, as I mentioned, with our IT department to make sure that we are integrating essential elements of our care plan into the electronic health record in a way that that information can be readily retrievable, searchable, and quantifiable, and it can be entered in a way that is not overly labor-intensive and time-consuming on our providers. Some of the elements that are essential to be included and retrievable in this mode include staging information, quality of life assessments, the advanced care plans, and survivorship care plans. We are implementing a new kind of clinic visit. We're calling it a teach visit, but once a physician sees a patient, initiates a new care plan that involves chemotherapy, after they're finished with the oncologist, they will have another discrete visit to the clinic where many of these important elements with regard to how their care will be special because of the OCM are shared with our patients. There's a specific letter that all of these patients will be given. We need to make sure they understand how to utilize the one number if serious questions or perceived emergent issues arise. They will be given additional information with questions answered with regard to the regimen upon which they will be started. And very importantly, they'll be instructed how, if necessary, to access one of our own emergency rooms rather than going outside the system where we have less of an ability to manage how an unanticipated problem is handled. Next slide. We have a large menu of healthcare professionals that work with supportive oncology services. We really want to be better at establishing criteria for hospice and palliative care referrals. I mean, none of us want to refer patients to hospice within a few days of the end of care. It's obviously much more appropriate to make those hospice and palliative care referrals at a time when they can do what they do best with some time to work with. We've defined an expanded role for our social workers, helping patients to better understand things like anticipated out-of-pocket costs, transportation, and any number of social issues that come up, which, surprisingly or not, doctors may or may not be fully aware of and fully understanding at the time they're doing their consultations and establishing their care plans. Also, it's through this supportive oncology group that we're able to help patients understand resources that they may be able to reach through the community and other outreach algorithms. And lastly, in terms of initiatives, it's really crucial that as we move forward, we identify what we feel would be critical data elements that will allow us to prospectively analyze how we're doing. We need to be able to clearly describe the resources we'll need to collect and manage that information as it's generated, because we are going to be responsible for utilizing OCM-generated data to develop our own OCM continuous improvement program. And obviously, all along the way, as we identify the kinds of data that we're going to be collecting, we want to be as certain as we can that it's really data that's relevant and can be helpful to us in continuously making the program better as we move forward. So that's a little bit of a 50,000-foot view of how we're approaching the problem, and I understand there'll be time later if there are questions. Thank you.
Well, thank you, Dr. Chapman. We are grateful to learn about the Teach Visits, ED integration, OncoStat clinics, supportive oncology services, and all of the innovative initiatives around OCM at Henry Ford. Tina, it's really great to have you with us. We're grateful for your sharing today about the initiatives taking place at Bon Secours. So Tina Chapman is the practice manager at Bon Secours with the Cancer Institute Medical Oncology. So with that, we'll turn the time over to Tina.
Good afternoon, and thank you, Sean, for the opportunity to share a brief overview of how we have come together as a team at Secours to implement the OCM. As you can see from my first slide, we have started off with identifying a core team of 6 individuals to begin our work. Our work started with breaking down the elements of the OCM and identifying how to translate that into our daily work. I will review in greater detail as we move through the presentation. And one of the things that I wanted to highlight is the work that we have already started creating an interdisciplinary team that identifies high-risk patients in an effort to reduce emergency room visits and or hospitalizations. We are meeting weekly, reviewing cases such as those with high symptom burden. Next slide. Care coordination. Our care coordination, whether it's at the initial diagnosis and treatment planning or a change in the treatment plan, involves nurse navigation, social workers, and financial counselors, as well as the providers. Next slide. So care coordination and navigation. This slide shows some highlights of what our navigation process entails. Coordinating appointments with providers to ensure timely delivery of the diagnostic test and treatment services, ensuring that appropriate medical records are available at the time of scheduled appointments for patients, and facilitating financial support, helping patients with paperwork if needed, offering referrals to other services, and cancer survivor outreach as well. Next slide. Our care coordination also consists of an interdisciplinary team group, which I mentioned earlier. In addition to that, clinical pathways are being created by our core team to accurately report and address distress, pain, depression, just to name a few. As you will see, all of this work takes the efforts of a true interdisciplinary team. And our navigation program is a process, not a person, and it's made up of several disciplines, as I've highlighted today. Our social workers, nurse navigators, providers, financial counselors, all are part of the work that we are doing to implement OCM and provide an environment of quality patient care, which is what we are working towards for OCM. Next slide. Quality of care. As you know, part of the quality of care is to implement the components of the IOM care plan, listed as I've listed here on the slide. Advanced care planning has been a very high focus with Secours. We have trained staff dedicated not only to talk to the patients about their wishes for end-of-life care, but to also ensure that this information is documented and honored. Oftentimes this helps the provider with honoring the wishes for the patient during the treatment plan. Next slide. So patient education. Our core team has taken a look at patient education materials to standardize our voice across the system. Currently reviewing and editing our chemotherapy teaching, symptom management tools, and other materials for our patients so that our patients will know or will know what to expect during treatment. We're also looking at better ways that we can educate our patients on clinical trial access. We have many clinical trials within the organization available to patients. Inform them of various community outreach efforts that are also available. Next slide. cost of care. So currently the process that we have in place for addressing cost of care involves our social work navigators addressing barriers to care, including financial burdens. However, we are in the process of bringing on dedicated financial counselors to offer support to our patients as well as the staff in addressing the financial toxicity our patients are experiencing. Our goal is for our financial counselors to be available to our patients along the cancer journey. By this we mean they will meet with the patient at the initial diagnosis to review the initial cost of care, and I think the focus is the actual patient cost of care, not necessarily the overall cost of care. So we want to help them understand that what their insurance benefits are, provide them with financial resources. And then from that point, our counselors will meet intermittently with patients for ongoing discussions regarding their cost of care. The thought here is that we would not overwhelm or place a heavier burden on the patient, getting that initial diagnosis and then being overwhelmed with a huge cost of care to be concerned about as well. So the thought is we could take this in steps and through intermittently discuss with the patients along the way. And then, of course, this also opens up an opportunity to identify issues that may have already come up with financial situations, and then we can address them as well and offer resources. Next slide. So cost-saving efforts. The focus on cost-saving efforts for Secours is nurse navigators. They play a key role in this part. They reach out to our patients the day after discharge to address any immediate needs, talk about their medication changes, ensure appropriate aftercare has been arranged, whether there be home health needed, medical equipment, or maybe they just have questions that need to be answered, and oftentimes that's a big part with cancer patients. They just have lots of questions and concerns, and just the comfort of having someone reach out to them often helps a lot. So our navigators, while they're talking with them, they will also schedule up their post-follow-up visit, and our goal is to arrange that within 7 days, and of course sooner if needed. Next slide. So challenges. Here at Secours, we currently have a manual process in place to identify our measures and capture our quality reporting. Moving forward, our goal is to explore ways to provide real-time clinical quality metrics, give prospective analysts and a prospective analysis, and identify opportunities to improve performance. We're working with IT now to create an OCM flag that will flag our patients once they are diagnosed with that initial diagnosis, and then that will help us with that reporting and to be able to identify those patients and then ensure that all of the steps are being completed for the OCM plan. Next slide. So as you can see on this slide, the OCM is a service delivery and payment model that primarily aims to improve cancer care quality while reducing treatment-related costs. I've kind of listed the ACOs on one side and then the OCM on the other. Both models, you can see that the focus is clearly on the patient. Shared decision-making, navigation, communication, financial planning, and palliation are all going to be key focus for our patients. And the emerging requirement for our patient satisfaction surveys, the transparency of utilization and cost will be key metrics for success. We're currently in early stages for implementation of OCM and continue to identify ways to improve. And so that brings us to the end, and I thank you very much for your time, and I will hand the program back over to you, Sean.
Well, Tina, thank you very much for sharing those innovative initiatives at Bon Secours with IDTs, care coordination, advanced care planning, financial counselors, nurse navigators. So we have a few minutes here for Q&A, and I'd like to pose a few questions to our guests who have these questions have come in. I'd like to pose a question to each of you, if I may. What has been the biggest challenge in instituting OCM for your organization?
It's hard. Well, I'll start. This is Bob. Number one, it's hard to just identify one single thing as the biggest challenge because there's so many challenges. Certainly, one very granular challenge, which we are asked to do, is to estimate out-of-pocket costs ahead of time for individual patients. One would think it shouldn't be, but that's pretty tricky to give anything but a very broad estimate. I think another clear challenge for us, I mean, we really, really want to make as much of this automated through our electronic health record as we can, and working with our EHR experts and our IT people to look at how much we can automate electronically in real time, even things that may be conceptually simple when they're put into a way that can actually be integrated into the EHR and utilized, become extraordinarily complex.
I would have to start off agreeing with Dr. Chapman. Estimating cost of care for the patient is definitely going to be a challenge. You know, it is. There are lots of software programs out there, and that you hear about offering that can figure this out for you. But I think it's a challenge for the patients, just depending on coverage and depending on their treatment plans. They may change along the way. Also, I have to say, quality metrics being manual, that's a challenge for us. Identifying roles among our navigators, our nurses, and social workers. Sometimes we have a little bit of overlap there, so clearly identifying that overlap and the roles for each, I think, is still a challenge for us as well.
Well, thanks for your insight on that. We have another question as well. Did either of your organizations include families and patients in that care redesign process? So using that shared decision-making model. Perhaps we could start with Dr. Chapman.
I would say including patient and family members sort of in the application process and in the sort of formal implementation algorithms that we've submitted to CMMI. No, there wasn't a lot of direct patient and family interface there. However, with the actual program, as it moves forward, there is dramatically more interface at the individual patient care level between our team of providers and associated healthcare workers and the patients and families. So I think the whole OCM program has created care pathways that involve patients and families much more for us, and I think that's a good thing.
Secours, we have created a patient advisory board, and we will begin our work group meetings in March, and we will be inviting family members to those.
Well, thank you for that. Dr. Chapman, a question here for you. You had mentioned about one of the metrics in OCM being that chemotherapy is not administered within the last few days of life. Is there a general clinical guideline for when chemotherapy should stop within the last X number of days of life?
Yeah, actually what I was meant to be referring to is that hospice care should be initiated prior to the last few days of life. But the same really holds for chemotherapy as well. And that is somewhat variable. For many diseases, particularly solid tumors, after a patient has had up to 3 lines of different treatments, you're way well into diminishing returns, and the likelihood of having usable responses from treatment begins to fall off dramatically. Obviously, this varies a lot from disease to disease, but I think it's very important that providers are well attuned to when, in fact, additional treatment, which all carries its own potential toxicities, is more likely to be toxic than helpful in terms of the quality of life of a patient. And there comes a time when you need to make a very important decision where the best interest of the patient is served by addressing their quality of life principally, as opposed to looking at the next invasive intervention you can carry out in an effort that may be perhaps futile to impact the natural history of their underlying disease.
Dr. Chapman, one question a follow-up question similarly has come up on this. You talked about hospice in your piece, and the question is related to OCM, and will OCM, do you feel, have an earlier hospice referral effect?
We certainly hope so. I mean, we are working hard to educate our providers. We have our own hospice program, within the health system, but ultimately, the referral to hospice is initiated by the providers. Like, occasionally, patients will request it, but it can be, it can require some very delicate conversations. It's important that patients appreciate the fact that that doesn't mean we're giving up. It means that we understand, given an individual set of circumstances, that if our main focus is quality of life moving forward, that may be the best option.
Well, thank you for that. Tina, we have a question I'd like to direct to you. You mentioned nurse navigators and a lot of the proactive things taking place there. In your opinion, is there an indication or a possibility for the future need of home visits to prevent patient exasperation?
Yes, I think that for a high-risk team, that would be probably an area that would certainly be an option to keep patients out of the hospitals and out of the ERs. We work closely with our palliative care team. All stage 3 and 4 lung cancer patients are referred to palliative clinics, and many times patients are seeing a same-day oncologist. And we have collaborated with the palliative team to set up our clinics in concern to meet the needs of the patient. we work very closely with palliative for home visits as well.
Well, thank you for that, Tina. And another question has come in. There's a lot of interest in alternative payment models secondary to MACRA. And there's a lot of discussion simultaneously that bundles seem well indicated for acute episodes, but interestingly, CMMI with OCM has taken on a chronic condition in a bundle-like fashion. What are your thoughts on that, Dr. Chapman?
I mean, our thoughts, at least my thoughts, is it creates a tremendous challenge to manage something like that effectively. I mean, in an acute situation, you're more likely to be dealing with a limited set of options within a limited time frame, so that your opportunity to manage it carefully is going to be present. With a chronic disease over time, that becomes a lot more complex because just simply over a period of time, there are more opportunities for unexpected twists and turns in the road along the natural history of the disease. So that I think it's an appropriate challenge. We need to learn and work through better managing those kinds of problems. But that's, I think, a very, very substantial challenge.
And Tina, if I may ask the same question to you, applying a bundle payment methodology to a chronic condition, what are your thoughts?
I would have to be similar with in agreement with Dr. Chapman. I think it's challenging, especially with a chronic condition. OCM is such a new project, and we're trying to just kind of get our heads around it, and from a patient perspective, billing perspective, I would say we're taking these challenges, you know, I would defer probably to our billing experts and our bundle payment groups here within the organization for better information on that.
Well, thank you for that. Well, again, we just want to thank Dr. Chapman and Tina for their perspective and their insights that they've shared. A lot of innovative things that we can learn from taking place around OCM. So I want to remind everyone that an audio recording of this conference will be made available and will be included in our weekly news summary. The next webinar will be on Wednesday, December 14th. The topic will be selecting high-value provider partners, keys and insights to selection. So if you have any questions about the ACLC or follow-up questions from this webinar, please email members@accountablecarelc.org, and we'll be happy to address your questions. So thank you, everybody, for joining us, and we hope you found this presentation to be worthwhile.